So in different nuclear volume is very important. And the pepper-Nicolau state is like pork steak. You plunge cells into fixative, well fixed. So you also fix the red blood cell. And then, so you have red blood cell, everything, and it's three-dimensional. And then I wanted to have a PEP state that's flat. And so it's ultra-fast PEP state. Air dry the cells, so cells are all flattened. And then you rehydrate it. All the red blood cells become ghosts. Cells are flattened, same focal plane. So same case, you have everything in the same focal plane. And red blood cells disappear. And then I was invited by Dr. Zina to Park Avenue radiologist. And over there, they did a lot of CT of the thoracic abdomen, a lot of breast. And had this Dr. Messina, Dr. Dorminsky also. And then went to Cornell with Lennox radiologists, only head and neck with Dr. Free. And in Park Avenue Radiology, they have a big cabinet. So after I'm gone, they just put the whole rack into the cabinet, closed door. And then this cart pushed to the storage room, so you couldn't see it. So it's very convenient. Also, I request to have a double-headed scope so the resident can learn too. And because breast FNA, pepper-Nicolau is very important. Like in this case, breast FNA, I saw was fat necrosis, but I always do ultra-fast PEP-C on the side. And then I saw tissue fragment. I realized that this is cancer, carcinoma, because they make a lot of lipid, the cells bursted. So it looked like backfish. So I can not tell you how many times ultra-fast PEP-C saved me when I told the patient on breast FNA. For on-site assessment, the clues I use, difficulty, nuclear volume, best friends, red blood cell, background symptoms, colloid nuisances, glycogen, you could tell. Also, the medical matrix, so chondroid sarcoma, sarcoidoid carcinoma. And then negative images, MAI, cytoplasmic process vacuums, very important. Infogranule bodies are very important. Eosinophils, you only see it on different, you don't see it on pepper-Nicolau plasma cells. And then I use ultra-fast PEP-C to see architecture features, papilla, solid follicle, and nuclear features, shape, formation, nuclear inclusion. And then cytoplasmic feature, like all PEP-C, keratin, melanating, etc.
Just can. Right.
I can. Okay. So here's a young man with periaortic nodule. So difficult. First thing is look for red blood cell. Red blood cell is same nuclear volume, same as red blood cell, it has to be benign. Then ultra-fast PEP-C, cytoplasm, say granular. So you put two and two together, benign granular cell. So it's granular cell tumor. And then this is the histology, granular cell tumor. And subcutaneous, it's not the lymph node, it's subcutaneous. So when I see tons of cells, it's not the lymph node. And then I use red blood cell, it's a little bit bigger. And then a lot of cells and foreign body giant cell reactions, pilometrioma. Because those are histology, gold cells and the pilomatrix, foreign body giant cells. And a year ago, I had the 12-year-old boy have a bluish subcutaneous. Why is it blue? It's already give you the clue. In aspiration, you see hair. And then you see a lot of cells. Those are pilomatrix cells. See, this cell is this cell. They're proliferating, making hair shaft. And those are those cells. And then cross-section of hair. So if you know the histology, you could figure out the cytology. Here's a 60-year-old man with 1-year history of level 2 lymph node. The lymph node is pathological. It's a big fat island. So, and then blood courses, and then cohesive epithelium. Those are carcinoma cells, the keratinized carcinoma. And then it's P16 positive, metastatic HPV positive squamous cell or pharyngeal tumor. Here's a Japanese man, previous healthy lymph node with a flat island, so something is wrong. And then a lot of cells, but there's no lymphogranule body or ultrafast PET stain. You could see cells are sticking together. And high power, you see this characteristic vesicular chromatin nucleoli. And it's nasopharyngeal carcinoma. And then you prove it by immunoether. And patient went to Mount Sinai. And then here's a HIV positive man with lymph node. And there's a gigantic monstrous nuclei. In the back, there's some lymphocyte, some plasma cell. And then here's too thick, hard to analyze. But you see those monstrous cells. It's really weird, very, very strange. And then I saw it was, it could be lymphoma. It's definitely malignant. So it's a malignant favor lymphoma. Everything's there. So you have to take surgical biopsy. So they took a surgical biopsy. And then here's a recon. It's those monstrous cells. And then you see plasma cell, and then here's some cells, the secure monstrous cells. And in fact, this is metastatic nasopharyngeal carcinoma in HIV patient with monstrous cells. It's really very interesting, so I want to share with you. And then I said, how come I missed the carcinoma? What happened? So I went back to the smear. And then those clusters, difficult to analyze. I didn't even look. You see, those are the typical nasopharyngeal carcinoma cells. These correlate these. And then, so here's a young man with nasal mass, Chinese ex-Bellevue patient. extending. So lymph node have small blue cells, but there's no lymphogranule body. And you compare with red blood cell, it's like 5-6 times. So it's definitely malignant. There's no lymphogranule body. Salt and pepper, endocrine. So you do synaptophysin positive, but cytokeratin negative. Of course, because it's neuroblastoma, of course it's cytokeratin negative. And then the nasal mass, so it's olfactory neuroblastoma. And so chemotherapy for 3 months, recut from histology. Here's a recut. And 32-year-old woman with nexus. It goes inspection, distilled water-like fluid. This is typical for parathyroids. So when you get this, you send it for chemistry for analysis. Also, before you could also air dry a drop and let it air dry crystallize. You could see the crystal. If you stain right away, all the evidence will disappear. But there's one time I decided, well, air dry is 4 hours. Then I could still see the crystal. So here's a contralateral cystic neck vaccine before thyroidectomy for papillocarcinoma. The surgeon wanted to rule out metastatic papillocarcinoma. And Dr. Messina did aspiration. And the cyst fluid coming out, it's clear yellow fluid. This is gross appearance of lymph fluid. So we took this to the lab centrifuge, and then you have sediment, and then you make a smear. And then you have small lymphocytes. So now you have your evidence. A tissue follow-up for this cystic neck lesion is this. This is recurrent. You can show me. And right cervical lymph node in a woman. This time, the cyst fluid is cloudy cyst fluid, and then outside difficult, very few cells. But take the whole fresh fluid back to the lab, centrifuge it, and then you have the sediment. You smear the sediment, and then same with ultrafast pumps. So it's characterized squamous cell carcinoma. So that's my approach. Park case with parapharyngeal mass, FNA. And then you have a lot of neutrophils, and then squamous cells and some cloudy substance. The squamous cells are benign, they're translucent. And then you have filamentous bacteria. So it's outside the actinomyces, brachiocephalus. Then another man with swelling submandibular mass to the size of a tennis ball a month ago, and then put on antibiotics, partially response. It's a Friday, last patient. And then I just, a lot of abscess. Oh, it's easy. Mandibular abscess. I didn't even do an ultrafast PET scan. And then tissue follow-up, the truth. It's false negative. The patient has surgery at St. Luke's Roosevelt. this is that abscess. And then you have infiltrating carcinoma. Here's in situ squamous cell carcinoma. And then the aspiration was just abscess from here, and all this was not sampled. But I never knew submandibular could have cyst. It was signed as squamous cell carcinoma arising from first bronchial cleft cyst. So I learned a year later a similar presentation. And this time I learned from my mistake. I did the ultrafast pap smear. And then I see keratinizing squamous cells. It's the same thing. So I tell Dr. Messina, make sure you sample the cyst wall. I even did the cell block. So I just said that atypical bronchial excision is required. I did not want to alarm the patient, so they took it out at Berkeley's. Here's the recut, and here's the first bronchial crisis with papillary in situ squamous cell carcinoma. So I found a mistake a year ago. I learned my mistake, and I get it right the second time. So this is the case report. So everybody knows second bronchial cleft cyst, but before those patients, I didn't even know submandibular area you could have type 2 first bronchial cleft cyst. Yeah. Here's a woman with a 4 centimeter submandibular mass, painless. And then FNA show a lot of cells, but it's very strange. Like they're merged together. It's weird. Anyway, it's not salivary gland tumor. It's very strange. And then the high power, see the negative images of all cells there. And then ultrafast pap smear, you see the interconnecting cell cytoplasmic process. So it's, and then you proof it. It's a proof of paraganglioma at this size, carotid body paraganglioma. And then you do immuno to prove it, CD56. So you put everything together, your cell detective, and then use immuno intelligently to prove your hypothesis. And then here's a tissue follow-up, because there was definitive diagnosis before surgery. So surgeons know how to avoid bleeding, so it's all clotted, and so just exercise. And they say, how come it's so different, cytology, histology? But actually, they're the same. Because in cytology, you smear it. In histology, you on block, you fix the whole tissue. You never get to smear it. Unless you do electron microscopy, you'll see cytoplasmic process. That's the difference between smear and paraffin blood. Here's a young boy with a neck mass. You have the skeletal muscle, and then benign spindle cell fibroblasts. See, compared with red blood cell, the nuclei very small. So it's left sternal mass. Skeletal muscle on ultrafast PET stay like skeletal muscle. It is atrophic fibromatosis coli. It's there with persistent neck swelling for weeks associated with headache. CT show intramuscular margin. FNA show a lot of myxoid substance and then spindle cells. The spindle cells compared with our red blood cells, they're very small. So they're benign spindle cells. And on PET stain, the content is very pale. It's benign. There's no hyperchromation, no irregularity. So it's benign spindle cells. It's diagnostic for nodular fasciitis. It's a recurrent. That's why you have this myxoid. And this was spontaneously resolved. And there's a man with midline posterior neck nodule for a few months. Family history of rectal myosarcoma. So Dr. Purely aspirated in his office. And I just see some spindle cell, very, not much. The blood cell, the width, it's about the same as red blood cell. It's just spindle cell regional, ultrafast PET. You have blank spindle cells and this brownish capillaries. And then high power, the spindle cells are benign. They're smooth, nuclear membrane, very pale. So I just said low-grade spindle cell neoplasm. And then tissue follow-up. Here's the tissue follow-up. That's that spindle cell. The surgical pathologist was brilliant, very experienced. So as soon as she saw this eosinophil, no immunostain was performed, just based on H research. Cytohistology based on tumor, intravascular peptide endothelial hyperplasia. So for teaching purposes, I order CD34 to show for why is it called. The surgical but never ordered this in just based on H research. Old-fashioned surgical. Here's a woman with neck nodule and associated with left arm numbness, a posterior neck. And then the aspiration show blank spindle cells and then other substance like antimony and nuclear. So it's on cytology side, not so for sure no. They even though confirmed it's then it's one. And then so that's the story. 10 years of worsening left arm numbness. So I wanted to wait for the tissue follow-up. I had to wait 3 years for this because surgeon refused to operate until she could stand it. Here's a record of this same month. see exactly the same. Brachial cleft axis shown. This is a NT resident with a nodule left maxillary sinus for you. And you have spinal cells coming out, but the spinal cell compared with red blood cell, you could put like 3 or 4 spinals. So it's very big. It's that good. And then on PET-CT, there's some necrosis, and then the nuclear irregularity. So it's most likely malignant, but in cytology, you have to say suspicious. So I say suspicious for 3 results sarcoma. Just a recap. As surgeon pathologists, they did the final diagnosis, fibrosarcoma, maxillary sinus. Woman with enlarging left mandibular joint nodule for 2 years. I remember this patient from Connecticut and show up at the Park Avenue Radiology because her doctor in Connecticut said, "Oh, don't worry about it. Don't worry." And then she came to Manhattan and looked for an ENT surgeon who referred her to Park Avenue Radiology. Red blood cell. See the spinal cell? The red blood cell compared with red blood cell, it's very big. Good for 4 or 5 red blood cells. Here you have a little cremation. So it's kind of suspicious for spinal cells. It's the recur. It's synovial sarcoma. Of course, I cannot say this. I just triage and let surgical pathologists make the final diagnosis. All I could say is, here's a famous African patient. He had this parotid mass, and you have mesenchymal tissue and then single cells. It's hard to read through mesenchymal tissue because it's not transparent, and single cells has simple vacuum. I really don't know what it is. Why know it's malignant? Because the nuclear volume, you could put 5, 6 RBC. But I really don't know until I got the ultrafast PET-CT. Then it's diagnostic. In this thick tissue fragment, you have lacunar cells, malignant lacunar cells. So it's chondrocyte. Here's an elderly man surgery for angiosarcoma of nose, now swollen purple lip lesion. Dr. Cutler's patient. So it was outside. A diff quick, it's just all blood. It's then diagnostic. But ultrafast PET-CT, after this, I see cells, spindle cells. And then I get the previous histology to compare. So it's the same. So it's recurrent. And it's swollen, also purple, means it's blood engorged. So it's recurrent angiosarcoma. Because surgeon said he doesn't want to do anything aggressive, just want to stage the patient. So head and neck, gum, and elderly man with gum treatment now with the lymph node. Metastatic carcinoma. And here's the gum tissue, squamous cell, recurrent squamous cell. And it's an African American woman. There's a blister behind her ear. History of melanoma skull. So I see very small disease cells. You shouldn't get those cells in a blister. And then they're really small and there's some vacuum. Here's the single cells you have to do in a single confirm. It's recurrent melanoma. It's ophthalmologist request on-site evaluation in his office. It's a Filipino man with worsening left eye pain for 8 months. CT showed left cranial mass. So searching with needle aspiration in his office. And then this is quick. You see, blood cells, you have big nuclei malignant with a lot of secretion. And then in ultrafast PET, you have this carcinoma. You see, nuclear convolution has to be malignant. Cells line. Cell block. Because I'm always very curious. I want to know what's this factor. So it's glycogen. Head and neck. Here's a skull, Chinese man with liver mass. Now I have a scalp mass. This is look like hepatocyte. In the wrong place. You have liver in the skull. Metastatic HCC. Lymph node, I rely a lot on growth. I refuse to look at the slide if the sonographer didn't give me 3 measurements. So if I see the 3 measurements, I don't need to look at slides. I could slide shoot my report. This has to be benign. I could say reactive lymph node. 1 pass. If I see an abnormal lymph node, fat highland, then it has to have some pathology. It doesn't mean cancer, but pathology. There are a lot of look like granuloma. You have a very clean background. There's no cases necrosis. Then consistent with sarcoidosis. This histology of sarcoidosis, we learned it as second-year medical student in medical school. Sarcoidosis. And Bellevue patient with they want to know lymphoma, AIDS patient. But in difficult, you could tell right away it's not lymphoma. You have numerous negative images. It's AI. Then you confirm with this on cell block. But this come 1 day later. You could tell right away when you look at cytology. And best friend for cytologists is Burkitt's lymphoma because it's so characteristic. You have medium-sized lymphocytes with deep blue cytoplasm and with lipid vacuums. It's just so classic. You used to have a lot of Burkitt's lymphoma at Bellevue. This is pathological lymph node. I don't know what it is. Here you have this big cells, it's Hodgkin lymphoma. Recently. Hodgkin lymphoma is cytologist's best friend. Here's a pathological lymph node. If I don't see anything in cytology, I'm going to send it for flow cytometry. I don't see anything. There's no granuloma, there's no carcinoma. So you have to do flow cytometry. The flow cytometry is diagnostic for B-cell CD10 lymphoma, low-grade follicular lymphoma. And perhaps they have small clean cells. But in cytology, it's almost impossible to tell them apart. This has, you see, this woman at the site of previous follicular lymphoma, but she never had chemo because surgeons said, there's only one lymph node, you're lucky. So there's no need for lymph node excision. They just took that out, now you are cured. And then at the exact same site, she had developed abnormal lymph node. Here's the diff quick. You have some large cells, ultrafast, look like a little follicle. So I think it's recurrent follicular lymphoma, sending for flow. But the flow is negative. It says there are 10% large CD10 positive cells, but no right chain exchange. So the dilemma is, should you believe in clinical and cytology, or should you believe in flow cytometry? I choose to believe in clinical and cytology. So it's a recurrent. So they took it out. Yes, you see, basement. And so it's recurrent. What's interesting is now they have so many cells. They said 10% CD10 positive B cell with very deep kappa restriction. That's why, anyway, you have to believe clinical flow cytometry is your tool, but you cannot totally use it like a Bible. You use it intelligently. That's the final fact. Matted lymph node, bad news. And it's definitely malignant. But should I do flow cytometry or should I do cell block? Could this be small cell carcinoma or could this be lymphoma? And then so I have to look for lymphogranule body, and I found that lymphogranule. So I said, okay, I'm going to do flow cytometry. And then I returned to cytology lab. I did ultrafast PET-CT. You see, thank God I did not do cell block because those are hallmark cells. Hallmark cells. So it's like nasal endoplasmic cell T1 lymphoma. Flow cytometry, Mount Sinai follow-up. It's a week. Salivary gland can be woman with rapidly enlarging paraswally. She couldn't even close one eye. Emergency, emergency to air dry smear cytology. Lymphoma diagnostic for high-grade lymphoma. And so repeat FNA by the flow cytology T-cell lymphoma. And they excise it, and then because they want to write the case report. Did all kinds of fancy study, and then primary parotid HTLV1 T-cell lymphoma. So following one cycle CHOP, patient's spatial paralysis markedly improved. It's a Cornell patient, HIV positive, 7-degree nodule. It's a tumor or lymph node. It has spindle cells. It's not a lymph, it's a lymph node. Very bland spindle. Because it's laminar positive, so it's capacity sarcoma. So there's no need for excision. Parotid nodule woman. It is so classic, basal cell, like jigsaw cell puzzle, membranous type. Here's another case with salivary gland with very small nuclei, oncocytic neoplasm. And one Sinai recurrence adenoma. He's a Cornell patient with fluctuating parotid mass. You see your best friend red blood cell. Look how big the new blood cell has to be malignant. Of papillary line. So it's a parotid carcinoma. And then surgical pathology find out salivary gland carcinoma. Cytologists cannot have those fancy diagrams, but we treat out is a malignant or not based on cytologic feature. A smoker with a parotid nodule and very few cells, very, very few, borderline non-diagnosed. But the cells, look at the nucleus, it's gigantic. Very, very difficult. So I just signed out suspicious for parotid carcinoma. The patient on the other side have a Walton's tumor, but this one, I just signed out Walton's tumor. This one I suspicious for parotid carcinoma. So here's a recut. I was wondering how come so few cells. We did 3 passes, just couldn't get it out. And then the record tells you why, because it's very fibrotic. So it's very difficult to extract the cell. And then here's the nerve. You have peripheral invasion, which is invading. So even if it's sparse, if you have malignant cells, you have to report it. You could say suspicious, but don't just say non-diagnostic. it's due to sparse thyroid. See, because when they did FNA, it's very hard to just get cells. You're lucky to get 2 cells. Here's the tissue power. Cells line. Here's a salivary FNA with cylindromatous pattern, naked nuclei. It's anaplastic, adenocystic carcinoma. And there's a lookalike, also cylindromatous pattern. However, the cells have abundant cytoplasm, and that's polymorphic adenoma. See, the reason why you couldn't see cytoplasm because you need electron microscope to see it. It's only 1 micron. You couldn't see it, even under oil immersion. Pain, irregular solid nodule, all very bad sign. You have look like adenocystic carcinoma, naked nuclei. It's a recut. You see, here's a peripheral nerve with tumor cells relation. It's TMBG. This it's very strange. It's almost look like inside out with naked nuclei. Totally different from the cruciform pattern. And this I cited as suspicious for adenocystic carcinoma. Reconfirmed memorial. It's cylindromatous. It's very tubular, very rare. And why parotid swelling, FNA, show a lot of mucin, and then you see a lot of small blue cells. Also, could this be lymphocyte? Well, how come they move like this? Look like a school of fish. Let me. Is it lymphocyte? Is it mucin with lymphocyte? So on side, I did the ultrafast PEPs. So it's not lymphocyte, it's epithelium. So it's low-grade mucoepidermal carcinoma. I always add a suspicion. So the patient went to bed physio. Here's a recall. Took 8 hours, very tedious to dissect the tumor. Parotid nodule, this is straightforward case. Lot of mucin, and then you have epithelium. Because parotid is a serous gland. If you have a lot of mucin, that's abnormal. So you have mucoepidermal carcinoma, a straightforward case. Here's a parotid nodule. It has this very strange negative marking. Gland cells. This is an example of secretory carcinoma. I did not make this brilliant diagnosis because patient already have this diagnosis, just raw recurrence. So I already know the answer. And this is slow growing mass with a lot of weird stuff. Medical really strange. There's some cells. I have no idea what it is. So, you see, it looks like mucin, and then a lot of concretions. Brownish, weird. And I really don't know. Since I saw cytoplasm, and I just called before I get adenoma with syndrome this guy. Patient has surgery and Cornell and frozen section also called phimorphic adenoma. But when they cut deeper, they find out all those deeper section, these are invasion. How come you have invasion? And then what are those stuff? And it turned out those are amyloid. And then once the cells have so much amyloid, they die. They become a tombstone. The cell with this, and then gets amyloid, get more and more, and cell die, become tombstone. This is amyloid. Really weird case. I guess I will never encounter this. But I like this case because shows give you a window, see the amyloid deposition, and then how it killed the cells. Another case, you have serous fluid, polynuclear. Polynuclear means protein synthesis, making a lot of serous fluid. This is a recurrent acidic cell carcinoma. Tennis ball submandibular case from could this be lympho? The case I had, the one was a fellow, and it was Pennsylvania, rare cohesive cells, and then salt and pepper chromatin neuroendocrine. In cytokeratin had dot-like positivity. Here's a close specimen. And the dot-like are interfilament button. It's very rare, but and I encountered twice. Why you have intermediate treatment? Because when you make smear, this intermediate film come off on the slide. So you have this but the button, Merkel cell tumor like during the cancer. And a corneal case, small blue cells with intermediate treatment button. That like Merkel cell carcinoma. It's the tissue. Last case is father of a ET surgeon with this long-standing mass. Cystic area serves solid air cohesion. And outside, I said, could this be Walton's? But there's no lymphocyte. And then, but when I do ultrafast PET cell on side, oncocytic epithelium, and the nuclear malignant, see, polynuclear. And then this very weird, I thought, could this be music? So all I know is carcinoma. And then the final diagnosis is a carcinoma of ductal epithelium and large epithelial cells through differentiation. And then I went back to cytology. I said, what's the large epithelial cells? And then by focusing in a different focal plane, I saw large epithelial cells. Another case. So here are finalized what I just showed you. It's my personal approach and my experience in, whatever you decide will be fine. Okay.
Thank you, Grace. That was really a very good exercise.
It's like the thought process. It's the thought process. How to be a self-detective. The things you do, the mistake you make, the lessons. Okay.
So we remember all those.
Okay. That's
Thank
it.
you for sharing. I can.
Anyway, the PowerPoint is here.
It's
So
recorded. Yeah. Thank you, Sue.